first of all, to welcome you all. My name is Lola Oni, and I'm the education lead for the Haemoglobinopathy Coordinating Centre for West London. I'll talk a bit more about the coordinating centres and what it means and what its implications are later on. But just say that this educational program has been organised by the HCC Education Group. Now, within this group, specifically for the midwives training and education, you've got Helen Hosking, who's the chair of the group. You've got Carmen Martos-Ordonez. She's also going to be lecturing on this session. You've got Joyce. Now I haven't got all the names in front of me, unfortunately. I didn't write down the list. But you've got about 5 people, Paula Sullivan, that are all part of this working group for the midwives training and education. So, you know, the objective of today's meeting is really to look at sickle cell and thalassemia and some of the key implications particularly to midwifery. So what we thought we'd start off with, I'm sure you've all been sent the program already, and what we thought we'd start off with is this session on the biology, the prevalence, genetics, pathophysiology, and clinical manifestation of sickle cell and thalassemia. Then we're going to have a lecture by Dr Mamta Sohal, who's going to talk about alpha thalassemia, because alpha thalassemia is an area that a lot of midwives say that they tend to have problems understanding and how to manage women that have been identified with alpha thalassemia. So we're going to have a lecture from Dr Sohal on that. And then I'll follow on from her session talking about the HCC and looking at what the HCC is, the National Haemoglobinopathy Panel as well, and what all this means in terms of, and we're going to say a little bit on that, but the main thing I'm talking about is about the genetic competency. So the genetic competency is the new one that's just been launched, and that genetic competency, the original one came out in 2013, but the new one just came out hot off the press on the 28th of January. And we'll talk about the implications of the new genetic competency, not just to specialist midwives like Helen and Carmen, but to generalist midwives as well, because it has implications for all of us. So we'll talk about that and then look at where, and then take questions and answers. So if that's okay, I think we should launch straight into the session. And our first session is going to be presented by Helen and Carmen. So over to you guys.
My name is Helen Hosking, and I'm the specialist midwife in haemoglobinopathies at Hillingdon Hospital. It's a role that I've had for the last 15 years. During the planning of this, all the specialist midwives from our area joined together to make the panel for the education programme. This included Carmen Martos-Ordonez from Imperial, Paula Sullivan from London North West Hospitals, Joyce Adu-Amankwa from St George's, Kate Israel from Chelsea and Westminster, and Elizabeth Erikdal from Central. But you've got me and Carmen to present this session to you now. Next slide. Next slide. Thank you. Thank you. During this session, go back, please. Thank you. During this session, myself and Carmen will cover pathophysiology of sickle cell and thalassemia. We'll also look at the prevalence, the inheritance, and the clinical manifestation of the disease states. Next slide. Haemoglobinopathies, otherwise known as sickle cell thalassemia and any other variant haemoglobins, are caused by globin chain mutations within the haemoglobin. There's over 1,000 different mutations, many of which have no clinical significance. Thalassemias arise from inadequate production of structurally normal globin chains. For example, an inadequate production of alpha chains will cause alpha thalassemia. Likewise, an inadequate production of the beta chain results in beta thalassemia. Because I thought Professor Layton was discussing alpha thalassemia in this session, I've really mainly focused on the beta thalassemia. The hemoglobin variants, these arise from an alteration of the globin protein structure. For example, sickle hemoglobin happens when the amino acid glutamic acid is replaced by valine, and hemoglobin C occurs when the glutamic acid is replaced by lysine. And both these occur in position 6 on the beta hemoglobin chain. On the whole, carriers are usually healthy and asymptomatic, but of course there'll always be exceptions to the rule. Next slide. As most of you should be aware, these conditions are recessively inherited. This means that both parents need to be carriers for the child to have a 1 in 4 chance of inheriting the disease state. Obviously, if one parent has the disease state and the other is a carrier, then this increases the chance the baby will be affected to 1 in 2. It's also important that at-risk couples are aware that the risk is the same for each and every pregnancy. Not that if they have 4 children, they will have 1 that's affected, 1 that is not, and 2 are carriers. Next slide. Different ethnic groups are more likely to be carriers than others, but again, there's always exceptions to the rule, so one must never presume. In high prevalence areas, all pregnant women are offered screening regardless of family origin. In low prevalence areas, screening is offered as a result of answers selected on the family origin questionnaire, which you all should be aware of. London is high prevalence, and high prevalence means that there is more than 2% of the booking bloods that are screen positive. In general, thalassemias are more common if you've got family origins from the Mediterranean or Asia, and sickle cell is more common in Africa and the Caribbean. The chart here also shows examples of populations who can be carriers of the main variants, which are C, D and E. Next slide. Haemoglobinopathies, they're the most common occurring genetic disorders worldwide. And in the UK, sickle cell disease is now more common than cystic fibrosis. Next slide. This slide shows the normal values for full blood count and hemoglobin electrophoresis. The antenatal screening laboratories all use a testing algorithm when reporting the antenatal screening results. The MCH, the mean cell hemoglobin, the hemoglobin A2 level, and the fetal hemoglobin level, as well as the presence or absence of any variants, enable the lab to decide on when to offer testing to the baby's father. And all the labs within England use the same screening algorithm. Next slide. Beta thalassemia carriers will usually be microcytic. This means they have small red blood cells in conjunction with a raised hemoglobin A2 level. Sickle cell or carriers for other variants will always have a hemoglobin A level, which is higher than the variant level. The V here is variant, so that could be sickle cells, C, D or E. Next slide. So now I'm just going to give a brief overview of beta thalassemia. Next slide. Beta thalassemia trait, beta thalassemia minor and beta thalassemia carrier are all the same name for the same. They all mean the same thing. So depending on what text you read, depending on the countries where you read all the text, you will see these different names for it. Being a carrier is harmless. However, many carriers are microcytic, and it's not uncommon for women to presume that they're just anemic. And, you know, I quite often see women in my clinic and they've been taking regular iron supplements for most of their life, and yet they only discover that they're beta thalassemia carriers through antenatal screening. Beta thalassemia major, this can be either homozygous or heterozygous. It reduces the amount of hemoglobin that's made in the body. So the body just can't make enough healthy red blood cells. In babies, the symptoms are clinically apparent. So in countries that don't test for this at birth, these babies will show signs or symptoms within the first 6 months. Hemoglobin can get as low as 20 to 60 between about 6 to 12 months of age. And the babies, they have delayed growth, pallor, they're prone to infections. The later they'll get skeletal changes, and jaundice is very common. The picture here shows a 14-year-old girl with the typical facial features of the iron overload. There's prominent frontal and cheek bosses, there's a saddle nose, and then there's the protrusive premaxilla. So, you know, notice all the cheekmont features. Next slide. Treatment for beta thalassemia major. This requires lifelong blood transfusions, on average about every 4 weeks. Having these regular blood transfusions can cause complications of iron overload. And the body can't naturally get rid of iron, so you need something to artificially get rid of it, and this is called chelation therapy. Now the picture shows a boy having chelation therapy via a subcutaneous pump. Historically, this is given over 5 nights a week for 12 hours. But, you know, there are modern treatments available, and newer treatments use a combination of tablets and subcutaneous pumps. But it's all geared to that person's specific needs. Iron overload, it can result in other chronic diseases like diabetes, liver damage, heart failure, delayed growth and delayed puberty.
Helen, you're breaking.
Oh, sorry, I couldn't.
You seem to be breaking up a bit. I don't know the sound.
I have no idea
the
why.
Sound is
okay.
Yeah.
I haven't moved.
Okay.
I haven't moved the muscle apart from my mouth.
Yeah.
Currently, the only cure for beta thalassemia major is a bone marrow or a stem cell transplant, and this requires a matching donor, and it's a complicated process. So, you know, it's not suitable for or available for everybody. Next slide. I never thought I'd end up, when I started doing the sickle cell and thalassemia 15 years ago.
Helen, I don't know, are you using a laptop? Perhaps you need to maybe change your position or what?
I'm using an iPad. Is that any better?
Okay. Whether to change position? Okay, somebody else said they can hear you, no issues. Maybe it's my end then.
Okay, all right.
Carry on, it seems as if it might be my end if that's the case. Okay,
I'll continue then. Yeah, I never thought I'd ever put up a slide about beta thalassemia major in pregnancy. But because, you know, historically women with beta thalassemia major just either didn't live long enough to get pregnant or were unable to get pregnant through due to delayed puberty. However, you know, because of the change due to increased life expectancy, the change due to IVF and better chelation therapy, women are finding that they are now at an age that they want to have children, and sometimes people get spontaneously pregnant as well. But it is important that women with beta thalassemia, if they are considering getting pregnant, they should inform their medical team so they can help her be in the best possible health before getting pregnant. And you know, iron chelation is quite toxic to the baby. It can affect the development, so it's best avoided in the early stages of pregnancy. So these women need specialist tertiary centre care. They are at risk of gestational diabetes if they don't already have diabetes. They're at risk of DVDs, fetal growth restrictions. So they are high risk. Next slide. In the past, beta thalassemia major, it was often fatal by early childhood, but with the current treatments, life expectancy is much improved. And there's about 1,000 people with beta thalassemia major in England, and you know, on average, about 20 babies are born each year with beta thalassemia major. Next slide. Yeah, over to you, Carmen.
Oh, hi. I'll introduce myself again. Carmen, I'm one of the screening coordinators at Imperial, Queen Charlotte site, and this presentation is on sickle cell disease. And I'll talk a little bit at the end about sickle cell disease in pregnant women. Sickle cell disease is a recessive inherited genetic condition. There are a group of blood disorders typically inherited from a person's parents. It's most common in population whose ancestry is from the Caribbean, African countries, Middle East, and some part of India and the Mediterranean. However, owing to population migration and mixing, is now of increasing importance worldwide, with increasing numbers of affected individuals. Sickle cell disease results from the inheritance of certain genotypes, and those will include homozygosity for hemoglobin S, which results in sickle cell anemia, hemoglobin SS, or compound heterozygosity for hemoglobin S and an interactive mutation, for example, hemoglobin S C disease or hemoglobin S D Punjab, as you can see on the table on the right-hand side, or hemoglobin S beta thalassemia. All these genotypes will give a similar clinical phenotype, but of varying severity. Not all sickle cell patients are affected to the same degree, the most common presentation in the UK are hemoglobin SS, SC, and S beta thal. Sickle cell carriers, they carry only one gene of those that causes sickle cell disease, and their genotype is hemoglobin A, S. They typically don't show any symptoms of sickle cell disease except when exposed to extreme conditions. For example, when they need a general anesthetic, they should let their healthcare professional know, including their dentist. They need to ensure enough oxygen supply, or those who might engage in intense sport activities like scuba diving or climbing mountains. They need to make sure they are well hydrated, they avoid extreme exertion, and not to be short of oxygen. Next slide, please. So a little bit on the genetics of sickle cell disease. Normal hemoglobin A is made up of 2 alpha globin chains and 2 beta globin chains. The structure of these globin chains is genetically determined. Sickle cell disease occurs when a person inherits 2 abnormal copies of the beta globin chain that makes the hemoglobin, and 1 from each parent. This gene occurs in chromosome 11. Sickle cell disease affects the quality and the structure of the hemoglobin within the red blood cells, which carries oxygen around the body. Sickle cell red blood cells have a shorter life, so around 10 to 20 days. Normal red blood cells will last 90 to 120 days. So this leads to anemia. The anemia of this illness is called by hemolysis, so it's destruction of the red blood cells because of their shape. So in these patients, the bone marrow tries to compensate, creating more, but is unable to match the destruction rate. Their hemoglobin level tends to be between 60 and 80 grams per liter. And the red blood cells, when it's deoxygenated, becomes misshapen and rigid. It has the shape of a sickle, and that's where the disease gets its name. Next slide, please. So unlike the normal red blood cells, which are elastic, they have a biconcave disc shape, which allows it to deform and to pass through the vessels. The sickle cells are rigid and are sticky. They clamp together and they stick to the blood vessels, and they cause blockages in the capillaries, and this reduces the oxygen supply to the organs. The sickling happens repeatedly and manifesting episodes of pain called crisis. These sickle red blood cells damage the spleen, which leads to an increased vulnerability of infections for these patients. And the reason why the spleen is so frequently damaged or affected is because of its narrow vessels and because of its function on clearing the affected red blood cells. The majority of patients with sickle cell are well in between episodes. Next slide, please. So signs of sickle cell disease usually begin in early childhood. The severity of symptoms can vary from person to person, and sickle cell disease will lead to various acute and chronic conditions. Some of them have high mortality rates. So these are some examples. Life-threatening vaso-occlusive crises. These are caused by the sickle-shaped red blood cells that obstruct the capillaries and restrict the blood flow to an organ, and this results in ischemia, pain, necrosis, sepsis. There's an increased risk of severe bacterial infection due to the loss of functioning spleen tissue, splenic sequestration, these are emergencies with the potential for the patient to die. They are acute painful enlargements of the spleen that are caused by trapping of red blood cells in the spleen, with resulting in a sudden fall of hemoglobin levels, with the potential for the patient to go into hypovolemic shock. Aplastic crisis, which is an acute worsening of the patient baseline anemia, and a stroke, which are quite common, especially in the younger patients. They're a result from a progressive narrowing of the blood vessels, preventing oxygen from reaching the brain, and silent strokes are more common than symptomatic ones. And you've got more examples there. Priapism, which only affect men, pulmonary hypertension, retinopathy, etc. These adverse outcomes are made worse if the individual experiences repeated crises. And you can see the picture on your right-hand side of the slide. That's pain described by sickle cell patient. It's like hammering into the bone. You can see the description of the pain. This pain can be anywhere in their bodies, back, neck, legs, and it's been described as throbbing, sharp, stabbing sort of pain. It's worth to mention that some patients have chronic pain. So even in between the sickle cell crisis, they will still experience pain. Next slide, please. Sickle cell crisis can be triggered by a shortage of oxygen, lack of food, dehydration, infection, sudden changes in body temperature, and anything that increases the physiological demand on the body, for example, pregnancy. So hence the majority of the care required by individuals with sickle cell disease is preventative and supportive care. Patients and families need support to understand the condition and learn how to care for it proactively. Next slide. So a little bit on sickle cell disease and pregnancy. Pregnancy in sickle cell disease has been associated with an increased maternal and perinatal morbidity, which can be minimized by careful management. There is a long list of complications on your slides. Some of the most common are restricted growth on the baby, miscarriages, increased blood pressure, preeclampsia, preterm labor, preterm birth, DVTs, PEs, etc. Pregnancy in women with sickle cell disease is a high-risk pregnancy. It should be booked for consultant-led care. Additionally, women need to be closely followed up by the Joint Obstetric Hematology Clinic. This service is led by an obstetric consultant specialized in high-risk pregnancy and a consultant hematologist with expertise in the management of sickle cell disease pregnancy. In the Northwest London sector, the specialist service is provided at Queen Charlotte's, and this Joint Obstetric Hematology Clinic is supported by a midwife with an interest in high-risk pregnancy. This woman should also have a review by the anesthetic team in the 3rd trimester, and they should always be booked for hospital delivery. Ideally, women with sickle cell disease should be seen preconceptually to receive information about how sickle cell affects their pregnancy and how their pregnancy affects their sickle cell disease in order to improve fetal and maternal outcome. Maximizing maternal health in this period can be done by reviewing their medications, organizing a general health with various tests, for example, checking their hearts, eye test, blood test, and it's an ideal time for genetic counseling to ascertain the risk of the baby for this mom or for this couple to be affected by a sickle cell related condition. This test should include a pre-implantation genetic diagnosis, especially for those women who find it unacceptable to have a termination but don't want to have a baby with sickle cell disease either. Information that is relevant for these women that we can discuss with them during the preconception period or when we meet them antenatally is the discussion of nausea and vomiting in pregnancy that can result in dehydration and the role of dehydration in precipitating sickle cell crisis. They talk about the tiredness and fatigue that is increased during pregnancy and especially in these women if they have anemia. Anemia can precipitate their crisis, so it's important for them to slow down, to reduce activities, and even stop work early if necessary, so they can look after themselves. Keeping warm, especially in winter, and infection. Pregnancy and sickle cell increase the risk of infection, especially UTIs and chest infections, so ensuring they're taking their penicillin, their immunizations are up to date. Unfortunately, some women will go on to have sickle cell crisis and their management will include reviewing their pain medication. They might need opioids such dihydrocodeine or morphine, fluid therapy, oxygen therapy, and treatment for any underlying infection, heparin and blood transfusion, and even exchange transfusion during pregnancy. These women can have normal vaginal birth. These women with sickle cell disease with a well-grown fetus should be offered elective birth via an induction of labor or elective cesarean section if indicated on obstetric grounds after 38 weeks of gestation. The pregnancy should not continue beyond the due date without a multidisciplinary discussion. Next slide, please. So sickle cell is now one of the most common serious genetic conditions in England and the most common worldwide. It used to be considered a disease of childhood, but at least 99% of children are now expected to live into adulthood, and life expectancy is improving and is now around 50 years old in the developed world. There are around 15,000 people with sickle cell disease in England, 250,000 carriers, and around 300 babies born each year with sickle cell disease. Next slide, please. And these are some resources. We've added the Sickle Cell Society and Thalassaemia Society. These are national charities that represent people with the condition. They're fully engaged with the NHS, with the screening programs, and their aim is to raise awareness of the disorder and support those living with the condition to empower them to achieve their full potential. You also have the e-learning modules if you want to access them independently. And again, a little bit more of knowledge and expertise. And that's the end of the presentation.
Thank you very much, Helen. Thank you, Helen. Thank you, Carmen. I think, you know, if we spend a few minutes for questions and answers, and then we'll go on to Dr. Sohal's presentation. So if we open up the floor for questions and answers, I suggest you unmute when you want to ask a question, and then mute when you finish asking your question. And then whoever's going to answer, we will decide between, I think, the two of them. Okay, any questions, any comments, any observations? The floor is now open for that. We'll spend about 5 minutes on this, 5-10 minutes on any questions and comments.
Thank you, both of you. That was really informative. You may have mentioned this and I may just have missed it while I was frantically scribbling down notes. Is this something, either of these conditions, something that can be had pre sort of genetic screening? Is that something that's offered to the family? Is that something that can be done just to see whether, I know that there is a risk of, say, if they're both parents are carriers, that there's a 1 in 4 chance of having a sort of a major thalassemia or a child affected. So is that something that pre-counselling, preconception counselling is offered and screening available?
Helen, do you want to pick that one up?
I can pick that one up. My name's Paula Sullivan. I'm the Sickle Cell and Thalassemia midwife here at Northwick Park. Preconceptually, it is better to talk to these ladies, because then I have done some of that counselling, and then I can refer these ladies onto Guy's and St Thomas's for PIGD, which I have one couple at the moment that went that route. They're now pregnant and will deliver in Northwick Park in the next sort of 10 weeks, I think. So it is better ultimately to offer that.
I just wanted to say it also depends on whether they know preconceptually.
Yeah,
so if they're carriers, they may well know, they may well not know. So if they know, yes, they can be counseled preconceptually, or they can be referred very early on. So we have early referral pathways for couples who are non-carriers, and then we can facilitate the screening pathway or the diagnostic pathway, whichever they choose. I guess with the with the newborn blood spot program, hopefully has increased or will continue to increase the number of carriers that know their own status. But yes.
Thank you.
And I just add something to that, because you know what you actually ask also is in terms of screening. I think it's important that we demarcate screening and testing. Screening obviously is where you're testing large populations of people that you don't know whether they have something or they don't, or that, you know, and usually people who are at risk of something. So in terms of the screening program, we're not offering preconception screening services, unlike the antenatal and newborn, which we do offer the national screening for. We did try some years ago to try and introduce and propose offering preconception screening in terms of haemoglobinopathies, but NHS England did not take that one up. And I remember, because at that time I was still working with the Human Genetics Commission, and we did put together a paper about that and the proposal to do that. But as I said, this was not something accepted, because when you're offering screening, it's obviously a large population of people that you're going to be screening. In terms of testing, a lot of the specialist centres can offer testing. So anyone can contact their local sickle cell thalassemia centre or even their GP and ask to be tested if they've not been tested before. And then they can go down the route that Paula and Carmen were talking about in terms of PIGD, etc. Okay.
Thank you. Thank you.
Any other questions? Yeah, in terms of specialist management of women with the disease state, you know, you'll find a lot of these women are managed by specialist haemoglobinopathy teams. And I'll talk a little bit about that in terms of, you know, haemoglobinopathy services is divided into what we call SHTs and LHTs. So you'll find a lot of hospitals, local hospitals, will manage, you know, their general sickle cell thalassemia patients. But NHS England has deemed it fit that all patients with sickle cell and thalassemia must also be seen by a specialist haemoglobinopathy team at least once a year. So all the patients with these conditions get seen by, even if they're being seen by their local team, if their local team is not designated as an SHT, they will also need to be seen by an SHT at least annually. And then of course your women with sickle cell disease and those with thalassemia major as well. We're only covering sickle cell disease because our HCC is for sickle, not for thalassemia. So the women with sickle cell disease are who are pregnant are automatically, as Carmen said, managed by the SHT, not their local haemoglobinopathy teams. So they're always routinely managed by an SHT, which is a collaboration, as Carmen said, of the obstetrician and the haematologist. So that's quite important for you to know the difference between the two. Anything to add from the others, or any other questions before we move on?
I'd just like to ask, maybe Mamta could ask this. At the moment, we have NIPT for conditions like Down syndrome. How close are we to getting the NIPT for sickle cell thalassemia conditions? That's the non-invasive prenatal testing rather than doing invasive CVS.
I think
yeah.
Oh, hello. Yeah, can you hear me? Can you hear me?
Yes.
Yes. Yeah.
So
No, I have to wear a mask because I share an office, so I'm just checking I'm not sounding muffled.
No.
So I think one of the obstetricians at Tommy's and Guy's presented some data at the ASCAT meeting on NIPT in sickle and thal, but I don't think it's in wide use. Well, it's not in use at the moment. I think that was more as in a trial setting. And the honest answer is I don't know how close we are to actually using it, but it would definitely be a lot better than what we're doing at the moment.
And from my understanding as well, a lot of they've done trials on it, as you said, but my understanding is that you can only use it for specific conditions like SC, but not for SS and things like that. So I think we're quite a long way away in terms of this patient group.
Thank you.
Okay, any other comments, questions, or should we move on? Diane.
Yes, I was just wondering, because we do the newborn blood spot screening, and I thought that was a national program. And isn't sickle cell and thalassemia one of those things that's screened for?
Yes, that's right. So it's a national program, and sickle cell thalassemia is a byproduct of the screening test. But yeah, it tests for sickle cell related condition. It screens for sickle cell related conditions. It doesn't mean that people are aware of their status, you know, even those that have had the screening with their babies. Some of them seem to know and some of them don't seem to know.
Okay.
Yeah, I can add to that as well. The newborn blood spot screening was initially brought about to look for sickle cell disease. And as a byproduct of the screening, it was picking up carriers for the variants, mainly sickle, C, D, and E. What it doesn't pick up is the carriers for beta thalassemia. And it is not there to pick up beta thalassemia majors, although as a byproduct, it will show if there's things wrong so we can do further testing.
Okay, thank you.
Any others? You can put your hand down now, Diane. Thank you. Okay, I think we'll move on. And may I now introduce the masked Dr. Mamta Sohal, who's a consultant hematologist at Hillingdon and an Imperial. And she's
I'm not at Hillingdon anymore. But,
oh, you've deserted Hillingdon totally.
Apart from doing paediatric clinic twice a month, I'm not. Okay. I'm through an SLA, but.
All right. Okay. So now you're fully in Imperial.
Yes, and I'm also very cold, hence wearing my scarf.
I was gonna say, have they turned the heating off over there or something?
I tell you, honestly. Anyway.
The things we healthcare professionals have to tolerate, eh?
Oh, well, thank you very much for inviting me.
All right, over to you, Mamta. Can we all turn off our screens, those who are not participating in this bit, and turn off our mics, please? Thank you.
Thank you very much for inviting me, and thank you, Helen and Carmen. And Helen, nice to see you virtually, as we used to work together at Hillingdon.
Diane, can you turn off your camera for a minute, please?
I'm going to try and share my screen, and hopefully it will work. So please tell me if you can see my screen. Can people see my screen?
Yeah. Yes, thank you.
Excellent. Yeah. Excellent. Okay, so my remit was to talk about iron deficiency anemia, or is it anemia of the thalassemia in pregnancy? And this picture is a picture outside Hammersmith Hospital taken last year on the anniversary of the NHS, when everywhere was lit up in blue. So just how people can unmute and just shout out numbers, but how confident are people in their knowledge of alpha thalassemias?
3.
Anybody else? Well, if Lola's 3, oh dear.
So if Lola is 3, I'm 0.
I know, I was going to say. Okay, okay.
Mm.
So what I'm going to do is do a little overview of alpha thalassemias, talk about the phenotype-genotype relationship, which in simple English means how, you know, the different genetic types manifest clinically. Then pointers to distinguish between alpha thalassemia from iron deficiency. And then if I've got time, I might mention a bit about management of iron deficiency in pregnancy. So we all know anemia in pregnancy is very common. 38% of pregnant women will be anemic, of which 55 to 70% of them will be due to iron deficiency. And why it's difficult to distinguish between iron deficiency and thalassemia sometimes is the fact that both cause small red cells or microcytic red cells. This picture is just showing a bit of Greek mythology. So Thalassa means a goddess of the sea, Haema means blood disorder, so thalassemia is anemia of the sea. So as Helen's already mentioned, classification of thalassemias are based on the Globin type and the clinical severity, which can go from a trait to major, and then intermediate, which is a whole a vast array of conditions. And this is the chromosomes. So the alpha chains are made on chromosome 16 with some other more primitive ones, and on chromosome level 11 you've got your beta, your delta, and your gamma chains. So your beta and alpha make up your hemoglobin A, your alpha and your delta make up your hemoglobin A2, and your alpha and your gamma make up your hemoglobin F. And thalassemia, as Helen's already mentioned, can affect any one of the globin genes, and in some instances more than one gene is affected, and it can result from mutations in or deletions of one of the upstream regulatory sequences as well. And why beta thalassemia, and I'm not supposed to be talking about beta, presents later in life, as Helen mentioned, is that basically when you're born, most of the hemoglobin is hemoglobin F, and that's alpha and gamma chains. And then as you get a bit older, around about 6 months, your gamma chains go down and your beta chains go up. And that's when you're meant to be starting to produce more hemoglobin A. And that is why it's at that point that children with thalassemia major become transfusion dependent. So this is, I think, if Lola, you're a 3, some of the hematology registrars, it just causes a lot of confusion for people, I think, alpha thalassemia. So as I said, it's on chromosome 16, and basically you've got 2 chromosomes, and they've each got 2 genes. So you've got 4 alpha globin genes normally. A carrier state can be any one of these 4. So you either could just be missing one gene on 1 chromosome, 1 gene on 2 chromosomes, 2 genes on 1 chromosome, and then the other one's all right. And then this is in red because you can also get non-deletional mutations if it wasn't confusing enough, which can cause carrier states. Hemoglobin H is where you're missing 3, and they are symptomatic. So these are all carriers and they are asymptomatic. Hemoglobin H, you're symptomatic, and this is obviously where you're missing all 4 genes, and that's where it's incompatible with life generally. And that's where you get the Hydrops, Fetalis. And if you look at the geographical distribution of alpha thalassemias, you know, it is the most common inherited disorder of hemoglobin. 5% of the population are carriers, and 1 million patients have various alpha syndromes, alpha thalassemia syndromes. And you know, you have global population movement as well, and about 5,000 babies a year are born with hydrops. As you can see, the alpha naught, well, you may not be able to see, the alpha naught thalassemias are more common in sort of Southeast Asia and some Mediterranean countries. So that's why you're more likely to see babies with hydrops born there. It's more common. So as I said, alpha thalassemias trait is like an umbrella term. And this is the nomenclature that we use. And they're all examples of alpha thal trait. All of these things here are alpha thal traits. So, as I said, so this is classed as, when you're describing it, this is classed as heterozygous alpha plus trait because you're only missing one. Here you're, and it's only on one chromosome, sorry. Here on 2 chromosomes it becomes homozygous alpha plus trait. And here, this is called heterozygous alpha naught trait because you're missing 2 on 1 chromosome. So on their own, they're harmless conditions in their own right. If you've only got 1 gene that's missing, all that you might see is a little trivial microcytosis, but no other abnormalities. If these 2 genes are missing like this, you will have a very low MCV with a well-preserved hemoglobin. And it's far more prevalent in Southeast Asian, southern Chinese populations and also certain Mediterranean populations. My colleagues left the office so I can take my mask off. Alpha thalassemia trait you will not pick up on your routine hemoglobin electrophoresis. So the only way you will make the diagnosis is by doing DNA analysis. Hemoglobin H disease is a symptomatic disease, which is, as I said, you lose 3 genes. And there you actually do get a moderately severe hypochromic microcytic anemia. And then the excess beta chains that you get form an abnormal hemoglobin with beta chain tetramers known as hemoglobin H, which is unstable, and that's why you get hemolytic anemia. And I wouldn't be a hematologist without showing you a few blood films. So this is what a normal blood film looks like. So you see your red cells with some central pallor, and these are neutrophils. And this is a normal looking blood film, but hemoglobin H blood film just looks very, very abnormal. And so that's why we love looking at blood films. And this is an example of what we call HPLC, which is what we do when we're doing when we say we're doing a hemoglobin electrophoresis. So on this side is what you normally see, and this is based on charge. So different hemoglobin molecules have different charges and have different retention times on this on the graph. So that's your hemoglobin A, that's your hemoglobin A2, and that's your fetal hemoglobin, and they will always elute out at sort of roughly the same place. And here you can see a peak here which shouldn't be here, and that's how you can pick up hemoglobin H. So all these things come together, the indices, the HPLC, and that you can put it all together to come up with a diagnosis. Hemoglobin Bart's hydrops is where all 4 alpha globin genes are lost and is generally incompatible with life. So in summary, so if you've just got 1 gene missing, you're a silent carrier, it's asymptomatic, you've got no hematological abnormalities. If you've got 2 genes missing, whether they're on the same chromosome or on different chromosomes, you can get a borderline asymptomatic anemia, and the red cells will be small. When you've got 3 genes deleted, you'd get a moderately severe anemia, and with hydrops, obviously, it's generally incompatible with life. Why is it important that we pick this up? Now, I'm going to use a case to illustrate why it's so important. And sadly, this didn't happen. I think this happened within the last 10 years. So this mother was a 41-year-old lady of Chinese origin. She'd had one previous pregnancy, a baby who's a year-old male baby who's well. And the father was 29 years old of Chinese origin. And she was booked at 14 weeks gestation at her local hospital, and triple screening for Down syndrome risk assessment was high. At 20 weeks gestation, she was noted to have increased liquor volume, and a fetal ultrasound showed an enlarged heart, mild edema of the head and abdomen. And then at 22 weeks gestation, she had massive polyhydramnios, and at 28 weeks gestation, she had rupture of membranes followed by spontaneous onset of labour, and had an unassisted vaginal delivery. Unfortunately, at birth, baby had no respiratory effort, had an APGAR score of 4 at 1 minute, was intubated and transferred to the neonatal unit, ventilated, had some surfactant and inotropic support. And these are the bloods here. Baby was profoundly anemic and had low platelets. And this blood film is very, very abnormal, and had lots of nucleated red cells here, which are precursors for making the red cells. And then they look back at things. So the mother presentation, her hemoglobin was 98. She had a low MCV. You can see that her hemoglobin electrophoresis is actually normal, and she had normal ferritin levels. So what are people thinking of here as a diagnosis? Someone can shout out, unmute. What do you think mum had? What would you do next if you saw those indices? Normal electrophoresis, she's Chinese, and she's got a low MCV, but her iron's normal.
Yeah,
Alpha zero.
Alpha zero, absolutely. Alpha zero thalassemia. And then what would you do next? If she's got alpha zero, you would
With she's from
test the father, exactly. Yeah. And he also had alpha naught. And so he also had alpha naught. And this is when we talk about hemoglobin electrophoresis, this is what we used to do years ago in the lab. And these hemoglobin electrophoresis plots. And here you can see hemoglobin Bart's here. So again, the different hemoglobins have different charges, and they elute out at different points, and you can pick up different hemoglobinopathies. But it's a fast eluting one, so it's hemoglobin Bart's. And again, this you can see it here as a fast eluting band. So it's hemoglobin Bart's. So the baby needed high ventilatory requirement, pulmonary hypertension, myocardial dysfunction, had group B streptococcus isolated from the placental swab, had a large intracranial hemorrhage at day 3 of life, causing midline shift. The life support was withdrawn upon discussion with patients, and unfortunately the baby died on day 3. So yeah, as you rightly said, alpha naught thalassemia most commonly occurs in Southeast Asians and Southern Chinese populations, also certain Mediterranean Greek Cypriot populations. You can get different sized deletions. Some include the sort of more primitive globin chains. And that's just a diagram of the different types of mutations that deletions that can occur, mutations that can occur. So obviously absence of alpha chain synthesis, no synthesis of hemoglobin F, A or A2, because alpha is the common one in all the hemoglobins, and it's usually incompatible with extrauterine life. So almost all the hemoglobin present at birth is hemoglobin Bart's, which is the gamma tetramers. It's unstable and unable to deliver oxygen to tissues due to high oxygen avidity. So you get severe anemia due to inadequate hemoglobin synthesis, together with ineffective hematophoresis and shortened red cell survival. and then that's why you get the big liver and big spleen. And the anemia and tissue hypoxia leads to cardiac failure and abnormal organogenesis and massive placental enlargement. And then the women themselves who are carrying a fetus with haemoglobin Barts have an increased risk of severe preeclampsia and antepartum hemorrhage. So, yeah, the woman should have been highlighted as an at-risk at booking due to her ethnicity and her red cell indices. As I say, you can't pick this up on routine tests. That you have to send the blood for DNA sampling to confirm the diagnosis. Yeah, the husband would then be screened, and he was also an alpha naught carrier, and then they should be offered antenatal genetic counselling. So, what is the risk of having a child with haemoglobin Barts if both parents are alpha naught carriers?
50%, is it?
1 in 4.
1 in 4. 1 in 4.
1 in 4.
1 in 4. 1 in 4. Correct. 1 in 4. So you all know this better. So do you still use this out of interest, the family of origin questionnaire?
We do, but we use it electronically. So we've just taken all the information and put it in our electronic request.
Okay.
Same category.
Yeah,
It's the same category.
Same at Imperial.
Same at Imperial. Okay. So that's
Same at Northwick.
excellent. So that's this bit of, that was alpha thalassemia. So this is also what you will see: a 25-year-old Caucasian woman, 13 weeks pregnant, gravity to para 1, significant hyperemesis in the first trimester. Here she's anemic, very low MCV. And this is what you may see in someone who's got chronic, severe iron deficiency. And so again, the blood film looks very different. You get very pale, small cells, and you get these things called pencil cells. If someone's had iron deficiency for a while, you can get this angular stomatitis, glossitis, or you get spoon-shaped nails called koilonychia. And when you're managing iron deficiency, there's iron available in your diet. There's obviously tablet or liquid form. I don't think we use iron at all really very much now, but then there's also intravenous. So iron-rich diet, you don't have to eat meat to have iron in your diet. You can get it from green leafy veg, you can get it from lentils, get it from all sorts of sources. When your oral iron is always the thing to start off with first if someone's iron deficient, and various different preparations, and often it's just trial and error whether which preparation people will tolerate. And I think I had to have, I had to have iron when I was pregnant, and I didn't tolerate it at all. It was awful. But anyway, but they all have different amounts of elemental iron in them. And then parental iron really can only be used in the second trimester. From the second trimester, it's contraindicated in the first trimester. But what I would say is, give people a good go with oral first, and it's best sort of taken on an empty stomach, if possible, to aid absorption, and take it with some orange juice. And the BCSH guidelines, let's talk about anemia. And they define it as hemoglobin less than 110 in the first trimester, less than 105 in the second, and less than 100 in the third, and in postpartum. And obviously you all know that you do another full blood count at 28 weeks and give women the correct dietary advice. You don't give them routine iron if it's not in the UK, it's not recommended, and you don't do unselected screening with ferritin. But you might want to do it in particularly high prevalence of at-risk women. And for a lot of women who are anemic, a trial of oral iron should be considered as a first-line diagnostic test, and then you're looking at an increment at about 2 weeks. If you've got a known haemoglobinopathy, then they should have a ferritin check. You do not give them iron unless their iron is low, unless it's less than 30. If you've then got an unknown haemoglobinopathy status, so beta thalassemia traits you'll pick up because they'll have a they'll have a high hemoglobin A2 on their hemoglobin electrophoresis, and you'll make a diagnosis. It's the alpha thalassemias traits that alpha thalassemias that you may not pick up. And so if it's unknown, then it is reasonable to start a trial of oral iron while you're waiting for the haemoglobinopathy screening. Whilst you're waiting, sorry, not for the screening, you're waiting for the tests to come back to decide whether what type of alpha thalassemia they have, if any. So how do you distinguish between the two? Are there any clues? So they, as I say, both can cause small red cells. Consider an alpha thalassemia if the anemia is not responding to oral iron, the anemia predates pregnancy, the microcytosis is out of proportion to the degree of anemia. So, with alpha naught trait particularly, the one that's associated, in Southeast Asia, the MCV will be really low, but the hemoglobin will be normal or near normal. Whereas in iron deficiency, the hemoglobin and the MCV drop proportionally. In alpha thalassemia, you may see some raised red blood cell count, and certainly with some of the more severe alpha thalassemia, so alpha plus trait, you won't necessarily have any specific blood film appearances. For some of the more severe forms, that they will have specific blood film appearances. How confident are you now of your knowledge of alpha thalassemias? I hope it's gone up a bit.
I think I've gone up to 8 now.
Oh, that's good, Lola. Anyone else? Thank you very much for listening. And this is a little graph that, so to get us through COVID, we had a consultant WhatsApp group, and one of our colleagues would send us little messages every now and then, and I particularly like this one. I thought that was very relevant. It made me laugh.
Well, it's making me laugh too.
Thanks for listening.
Thanks very much, Mamta. Okay, everyone, you can now come back in. And if we have any questions, please, before I go on to my session.
I wanted to ask Sohal if you could explain a little bit on non-dilutional mutations.
You're on a big ball game there.
Yeah, I don't think I
No problem.
It's huge.
Yeah, it's huge. It is huge, Carmen.
No worries.
Yes.
Carmen, I do a clinic on Monday with Jasmine. Come and find me.
Yes, we'll do.
And then we can have a chat.
Yes.
Because you have to remember, there's about more than 500 alpha thal mutations. There's just so much. And some of them are called really fanciful, novel names, but you could be there all day. But you'll find majority of the mutations that we see, certainly in practice, are deletional mutations.
Yeah, they'll be deleted. This is rare.
Yeah.
This is rare.
Yeah.
Although having said that, we did pick one up in the obstetric clinic because she was a bit more anemic than she should have been, and she'd been given iron, but her ferritin was normal and her iron studies was normal, but she was still given iron, and I was like, oh no, this is not right. Let's just have a look. And she's from the Middle East, and she had one alpha plus mutation and one non-deletional mutation.
But you'll find 95% or more are mostly most of them are deletional mutations.
Okay.
And that's why we tend to focus our counselling based on deletion mutations rather than the other alpha thalassemias, because they're so uncommon.
Yep.
Any other questions? Helen's sitting there looking very smug, so she's probably gone from a lower number to a 10 now, I reckon.
And I've stunned everybody else into silence. They're all like, oh God.
Oh, sorry, can I just ask, Mamta,
Yeah.
giving ladies with alpha or, with alpha thalassemia iron, would you recommend, is it below, if their ferritin's below 30 or 50? Because I've heard both figures.
I think 30.
30, yeah, okay. Thank you.
Any others? Are we all happy? We're all happy with the alpha thalassemia now? Speak now, forever hold your peace,
Yes.
as they say.
But
Well,
honestly, sorry, I was going to say, honestly, if it's any consolation, I know it makes a lot of registrars, scratch their heads and it confuses people a lot. Which gene? How many genes? What's going on? People get very confused by it.
It
I
was
always tell people,
good presentation.
when I came into the specialist field, alpha thalassemia was the one that really threw me. And I remember the consultant that worked with me at the time, Dr. Mary Horn. She taught me alpha thal so many times, the poor woman got so fed up with teaching it to me. And because I felt sorry for her, I had to go to the library and start learning it myself. And it wasn't until I actually studied it myself that I started to really get it with alpha thal. So don't be discouraged, because I think, alpha thal is a very complex one, and it's much more difficult to understand. I think what causes the problem is the terminologies we use in alpha thal. And that's why I tend to just stick to silent carrier, alpha plus, alpha zero, H disease, and Bart. I don't use a lot of the terminologies that Mamta uses, which are correct, but I find them makes it more complex. So, I just stick to the simple language, especially when we're counselling.
I think in pregnancy as well, people get confused on who to offer partner testing to.
Yeah.
I think the family origin questionnaire has really helped with that.
Yeah.
It's very clear on who you should offer partner testing to.
One more weekend. So
Yeah, it does. It makes a difference. It does make a difference. Yeah. Okay, any other questions, comments? Just looking at the time. Okay, can I just say thanks very much, Dr. Sohal.
You're welcome. Sorry, somebody else has come in my room now. I've got my mask on. See, I'm doing the correct PPE.
You're doing the right things. Good example to the rest of us. Yes. Well done.
Take
Brilliant.
care. I'll hang on to the end as well.
Yeah. Thanks, Mamta. All right, guys. So now we're going to go on to our next session, which I'm going to try and see if I can share my screen. I can see the program, but I can't even see the file. Just bear with me while I try and find the. Okay, what I thought I'd start off with, if it'll share, is a very quick overview of the HCC and NHP. I don't want to spend too long on this, but it's just to give you an idea. It's taking its time to load, but just to give you an idea of what it is. Doesn't look as if it wants to load. Bear with me. Basically, I'll talk it through, even if we can't get the slides up. Basically, in 2018, NHS England decided that they were going to review and revise specialist haemoglobinopathy services, and so they did. And so they came up with the idea of presenting a review, which developed into. Can you see my screen?
Yeah, can see now.
Yeah.
Yeah, except it won't let me show you the. Are you see them as individual screens?
Yeah, you can see them as individual screens. Okay.
So basically, they developed a program whereby they designated specialist haemoglobinopathy teams, which are the SHT. So there's about 24 of them in England. And then they designated specialist haemoglobinopathy coordinating centres, of which there are 10 sickle cell coordinating centres and 4 thalassemia and rare anemias. And we are part of the West London Sickle Cell Coordinating HCC, Haemoglobinopathy Coordinating Centre, and we're one of the thalassaemia with a number of other trusts. We're one of the thalassaemia coordinating centres. And there's one national panel, and all these have different functions, but one of the functions that the HCC have is for us to provide education and support to generalists as well as specialists within our HCC. Our HCC is made up of 3 SHTs, which is Imperial, which is the lead for the programme. So Imperial, London North West University Healthcare Trust, and St George's. Those 3 make up the West London HCC. So as I said, we are organising educational programmes, and one of them is the one that we're doing for you guys today. But we've had a number of meetings and training and international meetings and what have you. So just be aware that these are some of the changes. If you want to be kept updated, then you need to keep in touch with Ralph, who will be able to keep you on the list for circulation of information. And then there's one national haemoglobinopathy panel, which is for the whole of England. And that panel, most of it, membership of that panel is made up of individuals from the HCCs. And they have overall management of, not actually management, overall coordination of specialists, very specialist aspects of haemoglobinopathy. So, for example, who will go for bone marrow transplant and things like that. So it's just to give you an idea what this is about. And as I've mentioned, education of health, allied and other professionals is one of the key areas. But the major objective is to improve services across the whole of England. So we don't have what we had in the past of postcode services, so that you have a much more equitable service irrespective of where you live in the whole of England. But if you want to find out more about it, once the website is fully established, we will let you know, and you can read up, you can find out more about it. And as I said, we're part of the West London SHT. Okay, so I just wanted to give you a bit of an idea about, you know, how that works and what happens with that. So now I'm going to change over and we're going to talk about our genetic competencies. Any questions, any comments before I go on to that? Any comments, any questions? No, that was a whirlwind description.
Just a flag with the guys who are from the Welsh centres, and if there are any Scottish participants as well, that South Wales and Scotland are feeding into our HCC at the moment.
All right. Okay.
Slash in perpetuity will be.
Right. Okay. Thanks, Ralph. That's useful. Okay. So we'll go on to our counselling, genetic counselling competencies. And the main objective of, as we all know, of genetic counselling is to provide the family with a realistic view of the situation, the type of mutation or that's been identified in a family member, what is that, whether there's still a risk of somebody else having that condition, what are the risks, how does it occur, and of course what this may mean for the whole family, and to help them get through what can be a very difficult phase of their life. For a lot of us, you know, talking about these conditions, you know, we get so used to it, but we forget this can have a major impact on individuals and their families. So the aim of the competency, the competency group was put together by Public Health England, and I was chairing the competency group this time. As I said, this is a revision of the former competency document, which came out in 2013. And the new document, we tried to make it as user-friendly as possible, because we believe that the last document wasn't used as effectively as it could be. So the aim of the revised competency is to give practical guidance for those who are involved in providing genetic counselling services. And when I say genetic counselling services, that includes the midwives that are offering testing and screening to the women. Because what we fail to understand is that when we're dealing with a genetic condition, it's not the same as dealing with infection. So when you're talking to your women about being tested, they need to understand that this is a genetic condition, and they have a right in terms of choosing whether to be tested or not for a genetic condition. Genetics falls in a totally different remit to screening for infection and so forth. So it's very important that we realize that your generalist midwife also needs to have some knowledge and ability to convey information to those that they're seeing pre-testing and pre-screening. But the main part of this is really aimed, the main part of the competency is aimed at practitioners, which includes specialist nurses, antenatal and newborn screening coordinators, like I say, your general midwife, your genetic counselors, and other relevant health and allied care professionals. The objective of it is to promote your understanding and your knowledge and your ability to provide a competent service, and to understand the needs of the client group. And we're hoping that this document will be better used than the one before. And then the genetic counselling competencies, we need to look at what's in it. And what's in it is really to do with, we have to think in terms of how does it enable people to provide a good service. So we looked at how you would use it from identification to start with. So identifying those who, individuals as well as families, who will benefit from testing and counselling. We generated the competency into 8 categories. So you'll find there are 8 categories for the competencies. And the first category is identification. So you need to identify, I know that in our area, all the women are offered testing. So we do comprehensive testing. But in some areas of the country, they still do selective testing. But certainly in our HCC, all the hospitals in our HCC we offer testing to all women. So identifying those who are potentially can benefit from being tested. And then communication, understanding the importance of effective communication in supporting the individuals and families. Making sure we're using the right terminologies and not using terminologies that can be frightening for the women or the couples that we're seeing, because even just the word risk, to a lot of people, the word risk is quite scary. So we need to look at what terminologies we use, how we use it, our tone of voice and things like that. This is all included in the competencies. And then supporting personally informed choice. Not making the women feel we have to decide, make a decision for them as to what they need to do or what they should do. As I always say to my clients, I can't walk in your shoe. Your shoe fits you, it wouldn't fit me. So, how do we ensure that our practitioners are not being directive in the way in which they offer counselling to women and couples, recognizing that they need to respect the rights of their clients. And then, of course, having the knowledge of an understanding of genetics and the clinical implications of sickle cell and thalassemia. Without that knowledge, it's very difficult because people will always ask you, what does it mean to have sickle cell disease? And I know a lot of the midwives always say to me, well, I don't need to know about sickle cell disease. It's not my specialist area. But you'll find a lot of women, when you're talking to them about either being tested or about being at risk, they will ask you, what is the disease about? How does it manifest? What can happen? What services are available? And it's important for you to know, also the limit of the knowledge that you can give them. So you may need to identify areas where you need to forward refer for the couples to get more information that maybe you're not able to answer. But if you don't have the knowledge of the services or have an awareness of where you can refer on, then you will not be able to provide them with a comprehensive service. Then the fifth dimension was the use of genetic information for testing and the results. How do you interpret the results that you get? I mean, we just had a wonderful lecture from Dr. Sohal about alpha thalassemia. Obviously, if you don't understand, you know, what these results mean, because some labs don't actually give you the reporting, they just give you the FBC, and they don't really give you the specifics. And I've looked at some results around the country, and some of them are so confusing, even for me, as a specialist in the field. So you yourself must have an idea of what these results mean, what the FBC means, you know, what the MCV mean, and what it could potentially mean for that couple's result. And maintaining sickle cell thalassemia competencies. So making sure that you're keeping up to date in terms of the knowledge base. I mean, somebody was asking earlier on about, you know, PIGD, no, about fetal cells in maternal blood for testing. You know, that's because people are keeping up to date. That's why they know these things are happening. So if you don't keep up to date, you don't know what changes are occurring. So even if it's not your specialist field, so long as you're providing a service from a certain element of the service, then you need to keep up to date as to how it's managed. What is Public Health England making? What changes are they making? How do you ensure that you're giving up-to-date information and current information to your clients? And then the final thing is ensuring that you get ongoing support. I always refer this particular competency particularly to managers, because when people are providing this kind of service, they need an opportunity. Counselling can be very stressful, as I'm sure you're all aware, especially as midwives, and people need to have an opportunity to be able to get support, because some of these cases can be quite, I think, especially as midwives, can be very stressful and can affect us as individuals emotionally. So there needs to be an opportunity for people to get clinical supervision as well as ongoing support. So because if you don't get ongoing support, then you're not able to recognize what ongoing support you can give to your families as well. Because obviously if you're shying away from information that you should be giving because it's painful for you, maybe you've had a personal experience yourself, all those personal experiences mustn't come into your counselling session, but they may affect you emotionally, and therefore you need to know how to manage your own needs as well as the needs of your clients in terms of ongoing support. Because some of the women, you know, they already know from very early on in pregnancy, perhaps that they're carrying an affected child, but they've decided not to have you know, termination. And they've still got to go through the rest of that pregnancy knowing that their child is affected. You know, so how do you support them through that process for the ongoing aspect of the care? So, you know, it's quite important to recognize that. And then within that document, we've also incorporated this time learning outcomes and practical indicators. Unlike the last competency we did, this time we've actually put a few pages on how you can assess somebody as part of their individual performance review. Particularly for those of you who are working as specialists in the field, that part of the document can be used for doing your IPR or your appraisal to see whether you're still able and maintaining your competency in this area. So the outcomes are all incorporated through the whole thing, and the formal assessment is incorporated at the end, so you can measure yourself against it. We've included in there mapping to the National Occupational Standards, which is the gold mark. So we've made this book, this competency document, much more gold marked than the previous one. And we've also given you quite a lot of information about resources, useful websites where you can get further information, support and learning. So make use of it. It's already launched. It was launched on the 28th of January. It's on the Public Health England website. It's on the Sickle Cell Society website. I'm hoping it's already on there, but it may not be on the Sickle Cell Society website yet, because I was talking to the chair last week and it wasn't on there yet, but it will be eventually. But certainly it's on the Public Health England website already because it's already been launched. So what does this mean for you? I've already talked about in terms of preconception. because obviously, you know, some of you are involved with IVF unit, you're involved with, you know, different departments that deal with preconception women. And so therefore you need to think about, you know, what is your role and what part do you play in terms of preconception? Certainly in terms of antenatal booking, every midwife must have an idea of what these competencies mean for their practice. And then of course, once the results come back, and the results are normal, it's the generalist midwife that deals with that and says to the women, your test for sickle cell thalassemia was okay. We didn't see, you know, an abnormality of anything we're looking for. What you have to remember is we're not testing for every single type of haemoglobinopathy that exists. You know, we stopped doing that some years ago as far as we could. So you'll find there are specific haemoglobinopathies that are being looked for. But we have to always tell the women that, you know, there may be very novel ones that may be there, but we're not testing for those. So that's why I'm always very reluctant to say to people, your result is normal, because normality is dependent on whether you're looking for everything that exists and that could be found, but you're not. In the screening program, we decided on the key number of conditions that we're going to be looking at. There's over 1,200 mutations of hemoglobin. We can't look for every single one of them in every single woman. So it's very important when you're giving the women the result, let them know that maybe, you know, sickle cell and thalassemia haven't been found. Are you with me? Rather than saying, you know, your result is normal. Okay, and I think that's my last slide, and thank you very much. Any questions, any comments? You may now all return your screen and we can stop. Okay, thank you. I'm trying to stop my sharing and now the thing's not doing it. No, it doesn't want to stop screen. There we go. All right. Okay, any questions, any comments? We've got about 5 minutes. You can all come back with your cameras and your microphones. Any questions for any of our speakers or any comments?
Lola, I was just going to ask, once that's uploaded to the Sickle Cell website, if you send me the link, I can forward it round to everyone who's attended on the 2 days. Okay,
thank you. Just one quick comment that I wanted to make from my Dr. Sohal's talk. You talk about hypochromic and microcytosis. I'm not sure if everybody knows what that is. Could you please explain that to the audience?
Yeah, no problem.
Yeah.
So microcytosis means small, so small red cells, and hypochromic means that the red cells are not well hemoglobinized. So that's what that means.
So smaller and paler.
Smaller and paler, exactly.
Thank you. Any others? Just a quick thing to say, I don't know if you attended the Thalassemia MDT, Dr. Sohal.
No, I didn't.
No. Okay. They presented, I think it was UCLH that presented a case of a woman that had a hydropic baby, and they did a intrauterine transfusion.
Okay.
And the baby has been born, and they're going to continue to give post-birth transfusion now.
Oh wow, that's interesting.
Because I didn't know that they've managed, because I mean, certainly in all the years that I've been involved in this, you know, we've always said, you know, the outcome is usually very poor, but it appears as if, you know, the outcome is getting better in terms of transfusing these babies in utero.
That's true, but I think it depends on the mutations that are there and how big the deletion is, and whether I don't know what the long-term sequelae is of that as well.
Yeah, that's what we always emphasize to our parents, is that, you know, the long-term we're still not quite sure. I mean,
Yeah.
you know, whether it's really worth going down that route, but anyway,
Yeah.
that's another issue. Okay, any other comments, any other questions, everyone? No? Everybody's happy? You can all talk about this subject now? Okay, so I'll hand you over to Helen, who's the chair of the group, and she's going to do closing remarks. So the other members of the team of the education midwives group is Joyce Adu Amankwa, who I forgot to mention earlier on. Okay, over to you, Helen, to close up and round us off, and we've got 1 minute left.
Oh my, okay, thank you. That's pressure for me. I hope this session has been useful and diverse. I'd like to thank all the speakers today for such an informative programme. I'm amazed at how much information that we've covered in such a short space of time. I hope the sessions give you an insight into the new haemoglobinopathy centres. Just a reminder that we've had an introduction into the pathophysiology of haemoglobinopathies and its prevalence and clinical manifestations. And hopefully now alpha thalassemia is a little bit clearer and easier to understand. For all those future specialist midwives, I hope the new clearer counselling competencies have given you encouragement to further your knowledge. And, you know, finally, thank you all for attending and participating in today's session. Over the next few days, Ralph will send you an email to complete an online evaluation. And then most importantly, once you've done that, you will get a certificate emailed to you. And I think that's all I have to say, really. But thank you very much to everybody.
Thank you. Thanks, everyone.
Thank you.
Thanks for attending.
Nice to see everybody.
Have
Take
a good
care.
weekend.
Yeah, look after yourselves,
Bye.
everyone. Bye-bye.
Bye. Bye.
Thank you.